Today I am out taking a walk and talk with Susan Evans Axelsson and here in Ystad. And thank you for coming out for a walk.
Yeah, no problem. Hey, beautiful day, why not?
Exactly. And you are a research scientist at Lund University.
Yes.
And are working with prostate cancer.
Yes.
Prostate cancer and the treatment of prostate cancer was sort of an area that you sort of got inspired by, or is it just because it's a very hands-on problem to solve, or?
No, I mean, prostate cancer is, the thing is, it's completely treatable if it's caught early enough. But yet so many men are still dying of it. So it's something that we can really help. So I really like to push about men getting tested in that.
Yeah.
But we have to have options for men who have aggressive cancer.
Yeah.
And so my main work is targeting and therapy with radiolabeled antibodies and peptides. So I do that, but then I also work on a project where it's a EU project where it's called Pioneer, where we collect and collate already established prostate cancer-based data sets into one large innovative data set. Yeah. So that will help guide clinical practice as well.
Is that because that the background for prostate cancer development is not clear, so you need to have a better diversity in the data, or?
No, well, there's a few things on this. Men are treated completely different wherever they're diagnosed. So there's no general guideline. I mean, there's guidelines, but even a man in Stockholm can be diagnosed and given a completely different treatment regime than a man in Lund or Malmö. So by having this, we can actually, statistics. When you put a lot together, you get a better answer.
Okay.
So if we put all of these really quality data sets together, then we can ask a question and get answers that really we weren't able to get with just one data set alone.
No.
So this will help a clinician who has a man with these symptoms or this diagnosis. He can go and he can say this, and find these registries and these correlations of data that can help give him an answer and guide how he treats this man.
Wonderful. And this is a European?
This is a European.
So you're collaborating across different hospitals, or also?
Oh, it's academics, it's hospital, it's Innovative Medicine Initiative 2. So it means that we are public and private, so academic, but we also have pharmaceutical companies that also do research.
Okay.
So FDA companies.
So it's getting together to solve an issue.
Yes.
Is that what inspires you about this?
Oh yeah, I think it's great. And I mean, it's not just prostate cancer, there's others. If you get and you collate so much data around, if you think about it, you have these watches, they're getting data. You have just everything you do, it's like data. We gotta get it together. We can't just have it spread out everywhere.
No. And is that what drives you in science, is sort of like getting people together to solve, gather knowledge?
Well, now, I mean, it's definitely evolved on how I started in treating preclinically and moving on to see how this can really have an effect on men, the work that I do, and then actually getting the word out. And I mean, it's just, all of this evolves. It's just step by step,
Yeah. So what inspires you? Because you're also you're a preclinical scientist background.
Yeah.
You've been working with, I read one of your papers,
radioimmunotherapy.
Yes. Yeah. What is that?
So that's where we take antibodies and we label them with either a radionuclide that you can image so that you can find it, or for therapy even. So now a big thing that I was testing, I was a postdoc in Los Angeles, and one of the things we were testing is PSMA targeting peptides.
PSMA, is that a target molecule on the cancer?
Yeah, prostate-specific membrane antigen.
Okay.
And what we can do is we can label it with one thing where we put it in the man and we can see that he expresses the target.
Yeah.
And then we can put a label that's actually therapeutic.
So like almost like radiation.
Yeah,
in
that's
the
what
tumor.
it is. Yes, so and it's targeted therapy because it will go to just this target.
Yeah.
So I mean that's really good. It's starting I think it was first developed in Germany, and now it's starting to get bigger and bigger, and trials are going on, and so that was really fun to be a part of.
Absolutely.
Because we were actually working preclinically and clinically at the same time, so there were men being treated with it at the same time that we were going back and really trying to optimize everything, because that was actually brought into the clinic and into men extremely fast.
Yeah.
So then you need to go back and really like make it a quality, make sure you're giving enough dose, not too much, everything like that.
So because it seems like you always have one leg sort of in the applied clinical, and then another one is sort of should we just go a little around?
Yeah.
And another leg sort of in the basic science and how to get, because
but that's what makes it fun, isn't it? Yeah.
Is it? Because that was going to be my next question. It's like, what drives you as a scientist?
Yeah, I don't want to sit in the lab anymore, and just do that.
Yeah.
I want to get out and meet people and meet patients. So I'm meeting a lot of patients, patient group representatives, and I find this fun, and I find it exciting that we're actually helping. Yeah. So.
But why do you think that, this radioimmunotherapy, is that the future of treatments for cancer or prostate cancers particularly?
Precision medicine. I mean, I think we need to be more specific instead of just giving something that's going to really target all cells and really target, on and off target. So we really need to be able to give treatments that are not killing the man too. That's not like that's a bit much, but I mean that's not like, oh, I cured the cancer, but now he has this problem.
Yeah.
So we really need to be more specific with our therapies, and yeah. I don't remember what your question was.
But do you think that's precision medicine? Do you think that the collecting all of these data sets, is that part of that development towards improved understanding and precision in treatment of patients as individuals?
Absolutely.
Yeah.
I think so. Yeah, because now we can look and we can collect all this data into one, and we can say, okay, this new drug seems to be working. This new drug, we need to use it. And maybe you can't make that decision on just one data set. You really have to put things together and see how. You have to see real world evidence. That's the big kicker. You need real world data to give real world evidence that it's working.
Yeah.
We can't just throw something out there. And I mean, we have to get all this. We have to see how it's working. We have to see how it's working over time. We have to see how it affects men over time, how it can, its adverse effects, positive, negative, how, are we just extending a man's life for 1 month?
Yeah.
Or are we going to extend it for 10 years?
Yeah. It's because it's important.
A little bit.
Who gets prostate cancer?
It would be men.
Me.
Only. I can absolutely tell you that.
Really? Oh, that's good to know. Yeah. Then I won't get tested.
Yeah, that's good. Even though I do promote testing. Men. It is typically older men.
Yeah.
However, younger men can get it, 50s. It's usually more aggressive if they're diagnosed younger. But that's one of the things that's being looked at with guidelines to try to find the optimal time for testing. So getting a PSA test, prostate specific antigen. There was a big scare that went out a long time ago, not even a long time ago. There was a big scare where they said, oh, men are getting tested for PSA and they're getting overdiagnosed. They're getting overdiagnosed, so they're getting overtreated. Well, I don't really believe that people are overdiagnosed personally. I mean, you either have it or you don't have it.
Yeah.
So you're diagnosed with cancer. Now, they are overtreated sometimes, because with prostate cancer, you can have a cancer that you can live with forever and never have a problem. Or you can have an extremely aggressive cancer. And that's one of the things that we have problems with, being able to see which cancer is aggressive and which cancer is not. So when this happened and it went out that people were getting over-tested or over-diagnosed, they stopped. They really stopped doing PSA testing. And the thing is, I mean, PSA, it tells you something's going on.
Yeah.
So it's not, it's the best thing we have to give you an indication that something is happening. And you just have to be able to do smart testing. So we can't, so we just have to be smart about it. I don't think you should tell men to stop getting tested. I think we need to get guidelines and really determine at what age is the best, when to start, so that you have like a baseline to go off of. But I really think men, they absolutely should get tested, but you should absolutely have all the information so you can decide. Yeah. Because like I said, some cancers, you can, it would be terrible to tell a man you have prostate cancer, but you have to really explain to him that sometimes prostate cancer, you can live with it, but sometimes it's very aggressive, and you have to treat it. Yeah. So, I mean, because men still are dying. So me and all of our group and everybody working with prostate cancer, we're really pushing for this. We're really pushing that you're not scared to take these tests, but you have to be able to understand and know the options that you have. So we try to get it out more because, you know, a lot of funding was towards breast cancer mainly. And so now we really have to push and get funding for prostate cancer research.
But do you think that because there were this sort of hype for a little bit about like over-treated, over-tested, that has sort of scared away some people who might have been willing to do tests because... Yeah,
absolutely. Because then we saw a trend where men were being diagnosed with more advanced cancers. Yeah. So, because prostate cancer, you don't have symptoms. In general, unless it's too large and you're having problems urinating or something, you're not really going to have symptoms. So it's not like you go in and say, oh, my stomach hurts, and they're like, oh, you got prostate cancer. So, I mean, it's not like that at all. No. So when they stopped really doing PSA testing, then men were getting diagnosed with more or late stage disease. So.
Is that a role that we as scientists have to be better with communicating that? Because there's a lot of hype, there's a lot of information going out, that we need to, as scientists, go out and say what we're doing, both the good parts, but also sort of where we realistically is without killing hope.
Yeah, I mean, it's just we need to give people the information they need. We can't give scare tactics one way or another. We have to give them the information to make their own decisions and to be guided with their decisions. It's with the social media and everything, it was 2 days ago there was a newspaper article that somebody put on Twitter that was a lady saying how terrible PSA testing was again, and increasing that you shouldn't do it. And I don't...
When you see that, do you sort of lose hope a little bit, or do you sort of...
No, then I push more. Then I comment. And then the good thing is, patients comment. Yeah. So you see on these type things where patients say, listen, I had PSA testing and it saved my life. They caught it early. They caught it while it was still confined. Yeah. You know, there's somebody who commented on it that said, I was caught too late. Yeah. You know, if I would have had the testing, then it's possible we would have caught it at an early stage, a treatable stage. Yeah. So, yeah.
And that's also sort of, I imagine, what sort of drives you, is that you are making a difference in patients' lives.
I think so. I mean, it's what it's all about. I mean, it's the patient. That's what we're here for. That's what we're doing. And like I said, it's not what I grew up thinking I was going to do, but
what did you then think you were going to do now? When you
I don't know. Yeah, actually, my undergraduate's forensic science, so I thought that would be super cool.
You were going to CSI.
Yeah, that's what I should have been doing, running after, investigating, white bodysuit.
You're sort of doing that too.
Yeah,
just sort of from a different perspective.
That's true.
Yeah. All right, Susan, will you take it around? Is there anything that you think we should add to it? I'm going to add like links and notes in the description for
I can do Pioneer.
Exactly. Let's spread the word.
That's what we got to do.
All right. Thank you.
Thank you. Bye.
Bye.